Okay, y'all, let's jump into part 2. Emphysema. So this is defined as a progressive loss of the parenchyma of the lungs and then the dilation of the terminal airways. So this one is kind of interesting. It's caused by an imbalance of oxidants and antioxidants and an imbalance of proteases and antiproteases. So all that is to say, the damage is greater than the healing in this case. So there are two types of emphysema. There's one which affects the bronchioles, and there's one which affects the alveoli and alveolar ducts. One of them, the more common one, is the one you'll interact with more. So that's the Centria senar emphysema, and this one is associated with smoking. So nicotine inactivates antiproteases, and it causes the production of reactive oxygen species. If you all remember a little bit from patho before, reactive oxygen species, while naturally occurring in the body, if there's an imbalance, in other words, there's too many, they can cause damage to local tissue. So, in other words, remember that a protease is an enzyme which causes breakdown. The body naturally has proteases and antiproteases, so you have too many of the breaker downers and too many of the destruction ones, right, the oxidants. So basically you have too many breaking down enzymes and too many damaging ROSs. So what happens is eventually the terminal part of the airway is damaged and blown out. That damage is irreversible. Eventually the parenchyma starts to get damaged too. There's a genetic condition which can cause this too, but you really don't see it much. I have this here so that you know it's a thing. You're going to interact with this one for the most part. So 14 million folks in the US alone have this. So 14% of them are white male smokers and 3% are white male non-smokers, so it does occur in non-smokers as well. The rates are slightly less for white female smokers and for African Americans. The damage to the terminal bronchiole is the real etiology here. So collectively, these structures are called the acenas. So that's the bronchiole, alveolar sacs, alveolar ducts, and then the alveoli themselves. So that's where the gas exchange happens, right? And now you can see why emphysema is such a problem. So long-term exposure to smoke causes an immune cascade, if you will, and the alveolar walls are slowly destroyed. This also creates a lot of mucus hypersecretion as proteinases, in other words, enzymes that break down proteins, are released due to this inflammatory cascade, and you get a lot of mucus. You also get the loss of alveolar function, and the elasticity of the lung is lost as well. So what you have is a ton of mucus, lack of alveoli, and lungs that don't stretch. That's the pathogenesis here. The result, what we'll actually see, is a hypoxic person who can't breathe enough, and they get really pink. They're often called a pink puffer. If you've heard of a blue bloater, these are unkind terms. These are old terms, but if it helps you remember them, that's COPD. These folks get barrel-chested. So COPD gets really skinny, if you will. Emphysema gets really big. So their chest hyperexpands. They don't always have a cough, which is interesting. They do get very pink, though, and they don't always cough up phlegm. They do get short of breath. They have decreased breath sounds, which makes sense because part of their lung is lost. They are in chronic respiratory acidosis, and they get compensatory alkalosis, and they get cachexic around the lung as well. Accessory muscles kick in the advanced stage of the disease, so they always look like they're making some kind of weird face. Their neck muscles really flare out. They almost look like cords. They typically don't get clubbing of the digits, though. That's more of a COPD thing. So if you're looking for some differential diagnosis and there's clubbing, it's probably not emphysema. It's probably COPD. When you auscultate these folks, you might be able to get some percussion, but over time, what you're going to hear is wheezing on forced exhalation. They'll have more resonance, that's all the mucus, and it's also a little bit of the hyperinflation as well. The lungs are just getting bigger, if you will. So their breath sounds will sound far away. There will be crackles down at the bottom, at the bases, and the heart sounds will sound really far away as well. That's again because the lungs are flaring. Complications here are going to be cor pulmonale as everything kind of backs up and you get this pulmonary hypertension. You do want to know that those are complications of emphysema. For treatment, you try to give them a little bit of dilation and you give them supplemental O2. They do need pulmonary rehab. So these are for folks who are regularly rehospitalizing, short of breath, and they can't seem to catch their breath. Pursed-lip breathing works amazingly in these folks. This is partially because pursed-lip breathing increases airway pressure and it prevents the airways from collapsing during gas exchange. So because the alveoli are getting blown out, they're damaged and they're gone, it's easy for them to kind of come together and not be able to reinflate. So pursed-lip breathing helps with that. You absolutely want to teach these folks that technique. So pretend my fingertip is a candle and blow out the candle. You want to use this regularly with these folks. They do eventually, if this continues to progress in the bad way, not the good way, in other words, it's getting worse, palliative care is typically recommended at end stage. Chronic bronchitis. This is the excessive production of mucus, which causes a cough and expectoration. In other words, they hack up mucus. This needs to happen for 3 months straight in 2 consecutive years. That's when you get the diagnosis of chronic bronchitis specifically, as opposed to just acute bronchitis, which won't last nearly as long, nor will it be over 2 consecutive years. Almost always this is caused by smoking. The mucus-secreting glands are encouraged to grow more, and this leads to a lot of thickening of the bronchi and bronchial walls. So they have a chronic productive cough. So what's the difference between bronchitis and emphysema? Chronic productive cough is a bronchitis feature. Yes, they will get dyspneic. Also, these folks will get blue. So they will also get the blue bloater term as well. So know that this one is also, tends to come hand in hand with COPD, right? So keep that in mind as you're kind of teasing them apart. Bronchitis is part of COPD, remember that's an umbrella term. But emphysema specifically, they don't get blue, they get pink. Bronchitis specifically, they get blue. So again, this is a smoking exposure one, and they tend to get a lot of viruses that they'll catch because of all the gunk. These are the usual players. And sometimes this happens secondary to GERD, which is unusual, but not always. So it's present in 74% of all patients with COPD. And the prognosis here, it generally increases mortality. The other conditions will cause that more so than this. So remember again, basically smoke is an irritant, and it causes the hypersecretion of mucus by goblet cells. You also just have more goblet cells in this condition. So if you've heard the term smoker's cough, that's chronic bronchitis. The phlegm that they're going to produce is sometimes blood-tinged, but in general, it's clear to yellow-green. They generally won't have a fever with this, and they will have some chest discomfort, although this is more pleuritic. In other words, it's based on the lungs, it's not angina. And they'll wheeze. They'll make a sound when they breathe. So treatment for this, they need bronchodilators, they need steroids for acute exacerbations. Typically, they don't need antibiotics because this is usually viral, usually. They need to stop smoking, and they need pulmonary rehab with us. They benefit a lot from humidified air. That tends to help a lot. It decreases the irritation. Supplemental O2 is usually indicated for these folks, and sometimes they'll have a partial excision of their lung to remove a damaged portion, and rarely will they need lung transplantation. Let's jump over to asthma. So in reversible asthma, this is something you might have had as a kid. Maybe you even still have it now. This is a fully reversible airway inflammation that is usually in response to environmental trigger. The severity ranges from wheezing to a life-threatening airway closure. This is that bad. And interestingly, folks with asthma also tend to have eczema and what we tend to call hay fever, which is kind of like seasonal allergies, but not quite. It's similar. The etiology is not fully understood. It's thought to be a combination of genetics and environmental exposure. It is positively associated with tobacco smoke exposure, so whether you are a smoker or you've been in a house where there's smoking, there's a higher tendency to have asthma. This is common. A lot of folks have it, and a lot of children tend to have it. So it is not a benign illness, so we always have to remember that. It can seem like maybe not that big a deal because so many folks have it, but it is truly a concern. So you can get a death, you can die from an asthma attack. There's no cure for asthma. Lifelong monitoring is necessary. All we do is manage it. So keep in mind that the treatments are inhalers, and the side effects of inhalers are definitely something we'll tend to see because we're going to make these folks exert. So a lot of times they have to use an inhaler. And remember that the side effects of a steroid are going to be, they're going to get tacky, they'll flush, they'll sweat, and they'll kind of just generally be in sympathetic system overdrive. So just keep that in mind. It's also good to know if your person has another condition that has caused them to be admitted to the hospital, but they do need a respiratory treatment and they're getting albuterol or salmeterol. So if you come into the room and try to treat them, just know they're already going to be a little tacky, might be a little sweaty already before you even get started with them. So the usual lifestyle recommendations are made for these folks. But let's talk about non-reversible asthma. This is refractory. In other words, they're getting all the standard treatment and it's still not working. Also, they have to have regular steroids, corticosteroids. The distinction between severe and uncontrolled is a little bit tricky and is actually still an item for debate between pulmonologists. But this is really only about 3.6% of all of your folks with asthma. There are triggers for it. Usually these folks are pretty aware of that. Interestingly, these medications are triggers for asthma. Smoking can be a factor. The presence of aspergillus or candida in the air. A lot of times this is an occupational exposure that they're having, or they live in an area where the air quality is very poor. So let's talk about presentation and concerns. So if your patient is constantly sitting forward, they're trying to splint open their airways. It's like they're reversing the origin and insertion of the musculature that's secondary for helping with deep breathing. And that's partially why they're doing that all the time. That can mean that they're not managed properly. If they're in respiratory distress, these are yellow flags. They need to take their medication. They need to think about calling their physician and see if that's of concern. You may or may not need to stop treatment or at least modify. With kiddos, this can get a lot more serious. So sometimes if they're in an attack, they might not wheeze because they're just not breathing enough to wheeze. Their lungs aren't moving enough, their chest isn't moving enough, if you will. It might get to the point where they start to get Brady, and this is absolutely a red flag. Dial 911. So kids are a little bit different when they present with a severe asthma attack. They might just get kind of dizzy and quiet and confused. So unlike an adult who's going to verbalize what they're feeling, the kid might just get quiet. So keep that in mind. So this absolutely has PT implications because we cause them to exert. So that's something you absolutely want to be aware of. Furthermore, they might be taking a daily oral corticosteroid and it's altering their sleeping patterns, or it's just making them always kind of revved up, if you will. People can get kind of anxious on this, so just keep that in mind. Otherwise, the standard things fall in line, including maybe decreasing that occupational exposure, or moving if you're able to. But there's no cure, just management strategies. So more on the PT implications. This is a slide from Dr. Warmack in the past regarding corticosteroid use. You do want to be aware of these things. The items that I have italicized here are your yellow flags. So remember that corticosteroid use can result in a catabolic effect on many of your structures, particularly ligaments and tendons. It also makes you a little more susceptible to infection because your immune response is suppressed by the corticosteroid use. It can also lead to hypertension, so keep those things in mind. These are all yellow flags. Do keep in mind that hyperglycemia can be triggered by chronic corticosteroid use, so when you're in an inpatient setting, if they're getting really high on their sugars, we might not be able to work with them because we cause a little bit of a sugar bump at the onset of exercise activity. Be aware of this slide. Okay, let's shift over to bronchiectasis. This is a chronic condition where the bronchi get thickened from chronic inflammation and infection. This is permanent and irreversible. Mucus then starts to pool. So you can see that these kind of get blown out and inflamed, and mucus starts to form in there. So that's bronchiectasis. Specifically, you might be thinking, there sure are a lot of things where we're getting things that are getting damaged in mucus. This has to do with the anatomy. That's why I had that slide in Pulm 1, the Pulm 1 lecture, that showed you where things are happening. That can be part of the differential. So yes, it can sound similar, it's where it's happening. And you can see that bronchiectasis in some ways can be more severe because it can take up this entire part of a lung. If this is getting blocked off, this part of the lung can no longer do its job. Does that make sense? The key here is where things are happening. So you definitely want to go back as we're going through all of these slides if this is starting to get confusing, and it might at this point, and look at the anatomy of where each one of these is happening, because it might be further up the chain, further down the chain, and that's where you want to be aware. That's part of your differential diagnosis as well. So this occurs in every age group. It does affect individuals who are older or female a little more. The etiology tends to be a strong bacterial infection. So TB, this is the TB one. TB can lead to bronchiectasis. Folks with HIV also sometimes get this condition as well. And there is a viral component. Measles can lead to this, as can RSV if we're thinking of little ones. Fungal infections, if you get a fungal pneumonia. Bronchial obstruction, so in other words, there's a tumor compressing somewhere, and that can lead to bronchiectasis secondarily. CF tends to get this as well. And then if they have RA or Sjogren's syndrome, sometimes that can occur. Otherwise, this can occur hand in hand with diagnoses that I've already taken a look at. We'll come to pulmonary fibrosis next week. So there are 3 mechanisms here that tend to cause it: infection, airway obstruction, or a fibrotic state. Again, that's for next week. So most of these folks will have had repeated rounds of antibiotics and describe a long-standing cough over years, probably, with repetitive infection. So this is kind of how this tends to happen. So first, there's an initial insult, so that could be, for example, tuberculosis. The immune system comes in, and remember that the immune system is here to break things apart, but unfortunately it can get a little bit too aggressive. So this is why you do want treatment. This is how people die of some of these conditions. If you've heard of someone dying of pneumonia or something like that, they probably had a weird pneumonia, like a fungal pneumonia or something, and basically the immune system is constantly turned on. We do not want our immune system on all the time because there are trade-offs with the immune system's activity. Yes, it will destroy the foreign invader, so that could be the fungal thing or whatever, but neutrophils are releasing proteases to break apart the proteins of that foreign invader, and those proteins of the foreign invader are damaged, but as is the healthy tissue next to it. So all that is to say, the immune system is like a bull in a china shop. It accidentally damages things around it. It doesn't mean to, but that's part of the activation. So that's why we don't want this turned on all the time. So if this is turned on over the long term, you get airway remodeling. So this is permanent airway dilation. Why? Because you have enzymes tearing this apart. You'll lose cilia. Remember, cilia work to carry things back up so you can cough it up and get rid of it. Instead, junk is just staying inside. You're also getting mucus, which isn't getting transported out, so it accumulates. And guess what? That's a good area for bacteria to not only grow, but colonize, which means they're staying put. So now you still have an infection. Oh wait, we're still inflamed. The whole thing continues to cycle. So this is why bronchiectasis is such a serious condition. And again, it results from an infection that kind of goes haywire. So on presentation, these folks are short of breath. They're producing a lot of sputum. Usually they're coughing up a little bit of blood, and they hurt. These folks definitely get pleuritic chest pain. They're tired. Again, that immune system's really kicking in, right? It's using all of the body's resources. They'll have weight loss. Less commonly will you see clubbing in this condition. Less commonly. On imaging, the arrows are showing you the plugging of your dilated airways in this condition. So you can see the shape of the lungs a little bit, right? You can see kind of the tree-like pattern. And then you can kind of see right here where you can see the shape of it almost ghostly-like. This is classic. That kind of ghostly, shadowy sort of look, if you will. So what do? Sometimes these folks have to get on IVIG. So remember, that's crazy expensive. Liquid gold, right? They sometimes need an antifungal because fungal infections are notoriously difficult for the body to get rid of on their own. They might need steroids. These 2 things right here are in place to try and reduce the constant inflammatory state of the body as an antifungal tries to get rid of it. So it's kind of both at the same time. Turn off the immune system because it's overactive, but also help the immune system. So they probably will need one of those vests we were talking about back in cystic fibrosis, and they also need the active cycle of breathing techniques to get rid of all that mucus. So on your blackboard, there should be some documentation on active cycle of breathing. I do want you to have some familiarity with that. You probably need that more so for Dr. Jefferson's coursework, though. So they might need an infectious disease specialist, that's what ID stands for, to determine the appropriate antibiotic or treatment that's needed. They absolutely have to stop smoking. Sometimes they may need, there may be bleeding in the lungs, and they might need to be embolized. In other words, the surgeon will go in and cauterize the area and stop the bleeding that way. Sometimes one segment of the lobe is damaged so much that it needs to be removed, otherwise the immune system keeps trying to heal it. Severe cases can require single or double lung transplantation. Usually what I've seen is one lobe is removed. That's almost always what I've seen, is a lobectomy. So when it's associated with cystic fibrosis, this is progressive. Otherwise, though, if they're compliant and they get the right medication, they actually can do pretty well. So relatively good prognosis if they don't have CF. They do what they're supposed to do, and you got a good infectious disease doc on board who finds the right drug. Atelectasis. This is a rough one. This is a condition you will generally see in the ICU. This is the collapse of part or all of the lung, and it can be caused by a blockage of the bronchus or bronchioles or by pressure on the lung. So I've seen both of these. You can think of this as trauma. So in other words, if they're in a car accident and the steering wheel crashes into their chest, that can be pressure on the lung and cause atelectasis. Otherwise, they can have the bronchus or bronchioles. Remember, those are pretty high up in the food chain. That's pretty high up in the lung. That can get blocked, and it causes further down in the bronchial tree to collapse. So it will have to be reinflated, and they'll have to remove whatever was causing the issue. So remember that further down the chain, the surfactant helps keep things open, but if everything is blown out, if you have one of those conditions that obliterates the ansinus area, then surfactant can't be enough. So that's why these folks are in the ICU. Sometimes this happens after general surgery and they've been anesthetized. So in fact, this happens somewhat regularly, and this is why an anesthesiologist makes so much money, because they keep you alive and kind of keep this from happening or manage it and reinflate you. Okay, so on presentation, sometimes they're asymptomatic. They generally have decreased breathing, and imagine that, absent breath sounds, because that part of the lung isn't doing what it's supposed to. They will have chest pain, but remember, this is more pleuritic. They'll cough a bit, and the chest won't move. It's really strange to see. You can see it with the naked eye. Even a layperson can see it. The chest won't move as they breathe, and that's why they have to be reinflated, usually vented. So they'll do a chest CT to take a look. Sometimes they'll send a camera down during a bronchoscopy, see what's going on. They try to position this person so that the lung will re-expand. Sometimes they'll tilt the person in the specialized beds in the ICU. The head will be lower in the chest to try to drain out the mucus. Sometimes if there's an obstruction, they can remove it. If it's a tumor, then they'll go in and excise it. Medications will be given to open the airway, and during their recovery, once they wake up, they'll do a lot of incentive spirometry, deep breathing exercises, and they'll get supplemental O2. So see how this is gray right here? It's collapsed. Yeah. So this is what it looks like when they go in and take a look. They're trying to see, why is that airway collapsed? What can we do about it? Prognosis varies quite a bit with this. It all depends on why an airway collapsed. So these images here can show you different things that happen. Sometimes the lung will pull away from the wall and contract back. Sometimes just part of it deflates. Sometimes there's a pressure pushing up into it. All different things can happen to cause atelectasis, and that's why the prognosis is so variable. However, like I said, this is a fairly common respiratory complication after general surgery if they're generally anesthetized, and so they can manage that pretty well. That's kind of a known complication. Afterwards, though, they're at great risk of pneumonia.